Good morning, all, and welcome to our 24th Insight series. We have these webinars regularly every month on various topics. So this time the topic which is there, it is reimagining rural NCD care through community LED action. Now, our speaker is Ms. Gayathri Prashanth. She's the CEO of Healing Fields Foundation. This session will explore community-centric, innovative approaches for NCD care for remote, rural, low-access communities led by trained community health entrepreneurs. Now, let me speak a little bit about our speaker. So she has 20 years of experience in public health, community health, health systems, and women empowerment. She leads program designing, implementation, and research at the Healing Fields Foundation. She scaled the Community Health Entrepreneurs CHE, which is the model to reach 10 million plus people across India and Indonesia. Now, she also is driving innovations in rural healthcare access through telehealth-enabled community health workers. She's also the member of Rapid Rural Community Response Coalition Research Panel. So we look forward to your participation, dear all, and the insightful and enriching session which Ms. Gayathri will be providing us. We look forward to that also. Before I start, I would just like to tell everybody that please keep yourself on mute so that we can have this session clearly and there is no interruption in between. And also, if you want to say something, you can just message over the chat box, which is free for all. And we can access that. And if you have some questions also, you can send it in the chat box so that in between the session, we won't have any questionnaire. But after the session, we will be having the questionnaire. So we can take that up after the session. Okay. Fine. So let me hand over the platform to Ms. Gayathri. Thank you so much for coming, ma'am. And you can start the session now.
Hello, good morning. Good morning, everyone. And thank you, HSSC, for this opportunity to share some of our work and what we think is a solution for NCD care in India. I will just share my screen. Can you see my screen?
Yes, it is visible.
Okay. Before I get into the today's discussion, just would like to give a little bit background of where I am from. I'm here representing Healing Fields Foundation. This is a 26-year-old organization, and our primary focus is to build an ecosystem that ensures access to. Any question? Okay. Basically, we work towards building an access to affordable and quality healthcare for all. And we work on technology-driven equitable health access solutions, and very community-level resilient health systems is what we build. And we have been present over more than 10 states in India, working with 8,000 plus CHEs across that many villages. So this is some of our impact statistics, but I would not get a lot into this before. So just to start off and to build the context, this morning as I was reviewing what I'm going to speak today, one of my colleagues shared a recent article in Hindu, which talked about the raising burden of NCDs in India, and it mapped rural versus urban. Because when we talk of NCDs, and if you look at most of the NCD programs, there's a lot happening in the urban space. A lot of hospitals, there are some preventative packages and screening packages, all of that. But if we look at this, and what we see is the rural is not way behind. The gap is closing and the NCD incidence is increasing by the year in the rural areas. And what rural areas are facing is a double burden because we are still reeling with nutritional and communicable illnesses in the rural areas, and NCD is also increasing substantially. So before we get into, I'm just going to share a story from one of our areas where we work. This is Ramlal, who had come to us to our teleconsultation with a non-healing leg wound, ulcer basically, and high fever. And after the doctor had had a discussion with him, what we realized, we did immediately did a blood sugar, and his random blood sugar was 400 mg per dl, and he was a long undiagnosed case of diabetes. And what we realized was he had gone earlier to the local clinic, and they had given him some treatment but no counseling and no follow up. So he had not received any counseling, and he had no idea about any lifestyle changes or diet, and he had gone back, and within weeks his condition deteriorated. Preventable complications like stroke, blindness, kidney failure, all of that started, and Ramlal's age was just 39. And this is what we see day in and day out in the community. And the reason what it is showing us is basically delayed detection, fragmented care, and no continuity. And this is not just an isolated incidence. This is what the scale of problem tells us. As of now, we have 77 million plus diabetics in India, especially in rural areas, and 38% of the population with hypertension. And if you see, 50% of hypertension cases go undetected and untreated till they come up with a complication, by which time it is very late. And the referral completion rate is as low as less than 30%. So there is a healthcare system, but the last mile delivery, especially in rural areas, is still very inconsistent and fragmented. And if we look at it, why is this happening? Limited access to primary care, because the rural families, what do they depend on? They depend on unqualified medical practitioners. And so there is delay in referrals, even delay in screening. Most of the cases go undetected. And then women and elderly, there is a disparity in access to care, and women and elderly are always left out, and their access is always delayed. And silent progression NCD, and we are now hearing of malnutrition related NCDs, diabetes, type 5 diabetes, and pregnancies. Also, we are seeing that during pregnancy, the gestational diabetes and pregnancy induced hypertension are increasing, and these later lead to long term complications, which again go undetected. And follow up post diagnosis, the drop off is very common. In fact, a month ago when I was in the field, I had come across a person who had come to our camp. Blood sugar was 340, and when we further spoke to him, he said he was prescribed a medication at the PHC for diabetes, took it for a few days, had some gastric tissues, he stopped it. And we see this very often in the field. And why is this happening? What are the key challenges? Low awareness, late diagnosis. We see that in the urban, we are quite aware now of NCDs. We are aware of diabetes risk, hypertension risk, and but this is not the case in rural. They are still bogged down with primary challenges, primary care concerns, and awareness of diabetes and hypertension is very low. And many of the times these conditions go undetected. And lifestyle, tobacco and alcohol use is prevalent in the rural areas, poor diet, and poor diets because of lack of dietary diversity, lack of access to dietary diversity, and low physical activity, lack of awareness. And then there is weak continuum of care because the referral pathways are not clear. You have a camp, you detect a person with diabetes. What next? If they develop a complication, where do they go? So these are questions that we need to address. So that is what is leading to high treatment drop-off rates and limited access because they are still strongly dependent on informal providers. And there is also a shortage of qualified doctors. And that even if you have a camp, you do take a person in the village to do the camps. What about further diagnosis? You refer them for a diagnostic test. Where do they get their diagnostics done? What about the medicine availability, regular medicine availability? So these are some of the challenges, and added to this is the workforce constraint. At a rural level, if we look at, there are two main frontline functionaries on whom the entire health ecosystem of the rural areas is loaded on them, ASHAs and ANMs. They're already heavily burdened. ASHAs, maternal and child health, is the key component that they are addressing, and they're heavily burdened with what they're doing, and same with the ANMs. And so there is a limited capacity for NCD screening and follow up. So this brings us to what would be a suitable solution to tackle NCDs in the communities, especially in rural communities, and what would be a community-led and a community-owned model is what would be the most suitable. Why? Because there is a need for trusted and accessible care. So if the care is it has to come from outside, there is always a gap. There is always a dependence on an outside provider. So a community-led model brings healthcare closer, makes it available all the time. And if a local woman is driving behavior change, she is there, she understands the village realities, and she is well placed to promote behavior change, which is based on the foundation of the village existing realities. And she is there to do early screening, to create awareness, and ensure follow up happens, which, if we are dependent on an outside resource, cannot happen in the long run. And because of the presence of a local health worker, continuity improves outcomes. There is regular follow up, adherence, and care navigation. And when we are discussing this, one would often say we have ashas, we have Anganwadi workers present in the village. But if we look at critically, the ashas are already overburdened with maternal and child health, and Anganwadi's workers' primary focus is nutrition and early childhood development. There is no scope or bandwidth to add more on what they are already doing. So then what would be the solution? A woman who is from the village, who is empowered as a health provider and a community leader would be a solution, like a CHE, community health entrepreneur. She would be a community mobilizer who drives awareness, reaches out, and behavior change, ensures behavior change. She would be a health problem solver where she would be the anchor, health anchor in the communities, as able to identify risk, able to drive local interventions, care navigator for people who are already having an NCD, ensures that the care is proper care and referral happens for them, enables access to care, teleconsultations, provides basic first aid, and she will be the person who brings together the existing resources in the community, brings together the ASHAs, ANMs, and the government health systems. The CHOs works by collaborating with the CHOs and ensures the services that the community is entitled to reaches them. So that would be the person who could lead the NCD continuum of care in her village. So what would be the CHE-led continuum of care model? It starts with awareness creation, because most models that they work in isolation, either the awareness creation or just the care navigation. But this has to be a end-to-end model. So it starts with awareness creation, because where this woman engages with the community as a whole, creates awareness on NCDs, and then promotes risk assessment, early detection, and healthy behaviors. She would conduct household screening to identify risk, connects people to screening camps, referral, and public health facilities, and where she finds people with problems, ensures that they are connected to qualified doctors through telehealth consultation or through referral to the government health systems, and follows up to reduce treatment drop off. And the base of all of this is lifestyle counseling and behavior change, which this woman, being a part of the village, is able to lead in her community. So this is our model. What I just spoke about starts with awareness and prevention, risk assessment and screening. So high risk individuals are identified, and then they are screened through camps. And then the diagnosis is confirmed by referral to PHC or CHC, and they get a treatment prescription. And then again, this community health worker comes in and ensures that there is adherence and follows up regularly. The focus is long-term management and wellness. So in this case, how would the story have changed for Ramlal? He would not have had to wait for a complication like non-healing ulcer or an eye or a kidney complication to understand where his problem is. He would have been a part of screening camps, a part of risk assessment, and very early his diabetes would have been caught, and he would have received consultation from qualified doctors, and would have been ensured that he goes to the public health center to get the treatment, to get the medication and follow up. And the women in the village, the health entrepreneur in the village, would have followed up, ensured that he is taking his medication, ensured that his diet is changed, works with the family to ensure behavior change of the person and the family to make sure there is long term continuity and a long term wellness. That is the approach, that is the shift we are talking about towards prevention and towards wellness. And NCDs cannot be taken in isolation only with people who already have NCDs. What we need is an overall community change. The approach, the behaviors of the community have to change. Community have to recognize that NCDs are a big burden, and they lead to a lot of complications. So that is why it is very important to work with the community as a whole and engage with them. So some of the community engagement strategies that could be is group session, household and individual reach, basically on early prevention. And one of the things that gets missed out and very often is the physical activity and wellness. So this can be promoted through village level walkathons and yoga sessions. So one of the things that we had done is under the Arogya Mandir, Ayushman Arogya Mandir, there is something called Yoga Shivir, and they have recruited yoga trainers to give yoga sessions at the Arogya Mandir. Unfortunately, the attendance at these sessions is very low. People do not go there for yoga sessions. So we have started leveraging this, and these yoga trainers are coming to the village and doing yoga sessions for the community every week. So that thereby we are building awareness, and we are building the mobilizing the community towards physical activities. And nutrition and prevention. So dietary diversity is one problem that we have observed, that which is leading to poor diets, lack of fiber in the diet, and poor intake of protein. So to focus on this, we are promoting kitchen gardens to focus on fiber and green leafy vegetable consumption, nutrition demonstrations, and also nutrition exhibitions at the village level. And also, one of the very important thing is, while you may have a functionary at the village level, the local health systems have to be strengthened, and they have to work alongside the local health systems like the frontline health workers, CHOs, PHCs, and the Arogya Mandirs. And that is what we have built into the strategy, where the CHEs work very closely with the ASHAs in the village. As they identify people at high risk, they give the list to the CHOs and the PHCs to ensure camps happen in the village, and the high risk individuals are screened, and they are again referred to the PHCs. And also to build community ownership, what we work on is a village level NCD committees and peer support groups, basically to strengthen long term, because programs cannot be dependent on an organization or on a person. So even from a long term ownership by the community, we are promoting committees and peer support groups. So these are some of the strategies that we have engaged in. And how can this be? Because this cannot be a program in isolation that is run. So it has to get integrated with public health systems. It has to be a collaborative and a cohesive work. So how can that be achieved? By collaboration with frontline workers, linkages with health and wellness centers and public health facilities, and structured referral and follow-up pathways by working closely with the PHCs and CHOs. And another strategy that we have integrated is capacity building for the community on community-based NCD care, especially for ASHAs. So the ASHAs undergo training. Our trainers also work with the block level officials, and they train the ASHAs on the continuum of care and where the linkages and collaboration can be achieved. So we have successfully done this in several districts where the ASHAs have been trained by our trainers. And what we have observed is this training has helped in ASHAs to understand, because ASHAs are doing the CBAC. They are collecting data on the CBAC checklist, the high risk. But for them to understand why they are doing that, what would be the outcome, this training has really helped them, and they are collaborating better with the CHEs. So what we recommend is it has to be a loop which starts at the community level and then moves into the health system and then comes back to the community level. So the awareness of screening is starts from the community level, and then people move to the health system for diagnosis and treatment. And then again, the follow-up and adherence has to be done at the community level. That is the only sustainable model that would work for the large number of rural communities that we work. And how do we bring technology into this to make it more sustainable and make it more efficient and effective? So the risk assessment, what we do is we use a mobile application and we use AI for the risk assessment. Sorry, I was asked to do it in Hindi. I continued in English. If anyone had questions, I can stop and answer them in Hindi. Anyone want have
Ma'am,
any?
what you can do, you can in between you can use a little bit of Hindi to
Okay,
explain,
okay.
because there are
Oh,
few
okay.
jargons which are there which might be in
Sure,
English.
sure,
Few
sure.
people are not able to understand that.
Sure, sure, sure. Somehow I just continued in English. I'm sorry.
Not an issue, ma'am. Not an issue.
So early risk assessment, यहाँ पे हम AI कैसे use कर सकते हैं? What we focus on is basically treatment protocols and AI based structures for able to identify basically who's low risk, moderate risk, high risk. यहाँ पे हम AI यूज करके आइडेंटिफाई करते हैं एट द अर्ली रिस्क आइडेंटिफिकेशन. उसके बाद स्क्रीनिंग होता है. स्क्रीनिंग इंडिविजुअल के लिए भी हम प्रोटोकॉल यूज करके स्क्रीनिंग में रेफरल, किसको रेफरल करना चाहिए, किसको, हु कैन बी ट्रीटेड थ्रू अ टेली कंसल्टेशन, हु कैन बी रेफर्ड फर्दर फॉर ट्रीटमेंट, हु नीड्स फर्दर डायग्नोसिस. ये हमारा ऐप में वी डू दैट. एंड देन longitudinal care tracking. यहाँ पे भी it is very important to use data and technology so that we are able to track every individual and nobody falls out through the cracks. So every individual का alerts आता है, medication adherence आता है to the health workers, and periodic tracking, risk flagging, ये सब individually आता है. And then behavior change के लिए nudges चाहिए, and it has to be contextualized. जो आप एजुकेशन देते हो, डाइट एडवाइस देते हो, दैट हैज टू बी कॉन्टेक्चुअलाइज, कैन कॉन्टेक्चुअल नडजेस आना है. आई विल जस्ट शो ए क्विक डेमो ऑफ हम ये कैसे करते हैं. सो दिस इज कॉल्ड अपना गुरु. इट्स एन एआई मेंटर फॉर हेल्थ वर्कर्स जो रियल टाइम. सो एक हेल्थ वर्कर है, वो गांव में गई है, एंड शी हैज अ पर्सन विद अ, just like what I was talking to you about Ramlal, a person with a non-healing ulcer. सो शी पुट्स इन अ क्वेश्चन, क्या किए हम, ये नॉन हीलिंग अल्सर है, ये पेशेंट आए हमारे पास, हमको क्या करना है. सो ऑटोमेटिकली द एआई मेंटर गिव्स हर ऑल द स्टेप्स एज टू क्या कर सकते हैं, क्या कैसे रेफर करना है, क्या एजुकेशन देना है, होम लेवल फॉलोअप क्या करना है, पूरा स्टेप वाइज ये. एंड इट इज अवेलेबल इन ऑल लैंग्वेजेस एज आई एम शोइंग यू, इंग्लिश एंड हिंदी, एंड इट इज ऑल्सो वॉइस एनेबल्ड. So even she can give, if she is not able to type in the AI mentor, she can give a voice note and unka response bhi voice responses milega. So this actually helps community level health workers in getting real time information and real time data for them to guide them as to how to work with the communities. Yeah. So ये पिछले 6 महीने में वी हैव व्हाट वी हैव डन, उसका थोड़ा सम डेटा पॉइंट्स फ्रॉम व्हाट वी हैव डन इन द लास्ट 6 मंथ्स. सो हमने जो तीन डिस्ट्रिक्ट्स में शुरू किया है, 3 ब्लॉक्स में, एज ऑफ डेट 23,000 प्लस रिस्क असेसमेंट्स किया, एंड उसमें से हमको 4,355 हाई रिस्क इंडिविजुअल्स आइडेंटिफाई हुए. एंड ऑल्सो फ्रॉम द कम्युनिटी डेटा दैट वी आर कलेक्टिंग, 5,205 people who already have diabetes and hypertension. और हम इनके साथ कैसे, how are we working with them, जो ये high risk individuals है, इनको हम स्क्रीनिंग कैंप्स में फर्दर स्क्रीनिंग करते हैं, स्क्रीनिंग करके टेलीहेल्थ कंसल्टेशन फैसिलिटेट करते हैं. एंड एट द टेलीहेल्थ कंसल्टेशन बेस्ड ऑन आवर एआई प्रोटोकॉल्स, वो फर्दर रेफर होते हैं डायग्नोस्टिक्स के लिए, और सम ऑफ देम रिसीव द treatment advice with further diagnostics that is required. And यहाँ अगर आप देख रहे हैं, 44% of people with NCDs are females and 56 are males. And अगर हमारा एज डिस्ट्रीब्यूशन हम देख रहे हैं, मेजॉरिटी जो एज डिस्ट्रीब्यूशन है 40 to 74 एज ग्रुप में है. And that is where again the elderly, if you see, most of them would be above 50, the older people. And क्यों ये हो रहा है? If you see, the older people get neglected and the women get neglected. They don't access healthcare. They don't go out to the PHC or to a health center to get diagnosed or get treated. And इसीलिए when you take the diagnosis and treatment to the village level, that is when you see more women, more elderly coming into our camps, coming to our telehealth. तो ये एक हमारी एक CHE की कहानी है, सुनीता दरभंगा की है. सो एज अ पार्ट ऑफ हर रेगुलर वर्क, इन्होंने कैंप किया था अपने गांव में, NCD स्क्रीनिंग कैंप. एंड ये कैंप में एक आशा आशा एक्चुअली उनको मदद कर रहे थे, कोऑर्डिनेट करके, मोबिलाइज करके करने के लिए. आशा के साथ कोलैबोरेट करके ये सुनीता कैंप कर रहे थे अपने गांव में. देन आशा ने सुनीता को बताया कि उनको भी कुछ डायबिटीज सिम्टम्स लाइक एक्सेसिव थर्स्ट, एक्सेसिव हंगर है, कभी चक्कर आ रहा है. तो सुनीता ने उनको एडवाइस किया, व्हाई डोंट यू गेट योर ब्लड शुगर चेक्ड, आप भी कैंप में स्क्रीनिंग करा लो. एंड जब स्क्रीनिंग किया तो पता चला उनका ब्लड शुगर बहुत हाई था एंड एक्चुअली अर्ली साइंस ऑफ डायबिटीज भी थे, इंक्लूडिंग आई प्रॉब्लम्स एंड विजन इश्यूज. तो इमीडिएटली सुनीता ने उनको PHC को रेफर किया, PHC को कनेक्ट किया वहां पे, एंड मेक श्योर दैट उन्होंने ट्रीटमेंट, एडहेरेंस ट्रीटमेंट लिया, उसको फॉलो अप किया. एंड सुनीता हैज गॉन बैक एंड रेगुलरली फॉलोड अप टू मेक श्योर उन्होंने अपना लाइफस्टाइल चेंजेस बदला. And now her blood sugars are much more under control. She is taking her treatment regularly, and she's also been referred for further evaluation of her vision. So this is how this model has been evolving. And some of the learnings that we had over this last 1 year of implementing this model is, local women आपके लिए will be the ideal people to drive NCD care in their villages, because mainly the trust, and women are custodians of health, and community based engagement महिलाओं से बेहतर होता है, and trust build हो सकता है, and early screening. And सबसे important, and I don't think I need to stress more on this, all of us know early screening is the most important to avoid complications. एंड बिहेवियर चेंज एक बार एक सेशन कर देने से या एक वर्कशॉप करने से बिहेवियर चेंज नहीं होता है, बिकॉज एस्पेशली इन द कम्युनिटीज वी आर वर्किंग देयर इज अ लॉट ऑफ myths, there's a lot of beliefs and about diet. And इसीलिए behavior change करना needs a long term continuity. Even ideas that, अभी हम ठीक है, so why do we need to worry about diabetes? We don't have any symptoms. To get them to change their behavior to more preventive and wellness oriented approach needs long term continuity. It is not something that can happen in a day, in a month, in a year. It needs long term follow up and continuity, and that is why you need somebody in the village who keeps pushing, who keeps following up, and who keeps continuing her engagement with the community. So that is why the CHEs can strengthen the public health system. They can work with the frontline health workers to basically linking them to formal care pathways. And community ownership is the key here. It has to be owned by the community, for the community, by the community, with the community. And it has to be digitally enabled. Data has to generate insights, and these insights has to be used both by the public health system and the community representatives to basically drive change and to improve impact. So yeah, this is what I had to say, and I'm happy to take questions. Thank you, HSSC.
Thank you so much, ma'am, for this lovely session. I would now, this session is now open for question answers But if you have any questions, please you may ask, ma'am, and we can revert on this to you. And before they go, okay, we have Mr. Ravila who has raised the hand. So you can just tell, please. So you're not audible. Please remove. Yeah, please remove from mute.
Cannot hear you.
Just give me a moment, ma'am. Maybe there's some technical issue.
Yes.
Just give me a moment. So please try now if you're able to remove from mute or not.
Yeah, thank you.
Okay.
Thank you. Yeah. Thank you for this very important presentation, Dr. Gayatri. One request, kindly give your contact details in the chat box for
We'll do
linking
that.
up later. I have a number of questions. You call them as community health entrepreneurs.
Yes.
So maybe you can, I'll ask all my questions. Maybe you can expand on the entrepreneurship part. I mean, do they kind of make money doing this or what it is? The other larger question is what you describe is almost the job description of ASHAs. What they ought to be doing in the community for the population they serve. So I recognize there are always challenges in the field, in operational. So is this something that is happening in parallel, or it's going to be very tightly integrated with working with ASHAs is different from making the ASHAs do the work. So I just wanted clarity on that. And again, is the larger goal of your organization to develop, do pilots to develop models which can then be scaled or shared and scaled, or you're also into taking some large geographies and actually providing care? And these are some of the questions that I have.
Okay. Maybe I'll start with the Asha's question and then come back to the other two.
Yeah.
So yes, this is not a parallel model. And I do agree. I mean, the structure, the way they are working is very similar to what are doing. And Ashas are doing that very well for MCH, right? They are doing an excellent job with maternal and child health, the follow-up, the continuum of care. They're doing an excellent job. But all of us also, I mean, we are also aware, and having worked in in the community and in public health, Ashas are already overburdened. I mean, as of now, anything that is related to rural health, Ashas seem to be the primary person, and they're already overburdened with what they're doing with MCH, plus the registers, the data, and any survey, it is done through Asha. So they are already overburdened, and they do not have bandwidth to take up another focus area. And NCDs is not something which can be managed by just doing a CBAC at once and just organizing a camp. It needs a long-term continuous follow-up, which Ashas as of now do not have the bandwidth. So what we are proposing is not a parallel, but a cohesive work where this could be a model for scale by the government, where you have, like you have Ashas as a layer for maternal, child health, and other primary communicable illnesses. You have another layer who focuses on not just NCDs, along with that, the elder care. If we look at elderly in the rural areas, there is no access, no care at all for the elderly. There is so take up elder care, adult care, and elder care at the community level, and we need a layer of a primary health worker at a village level. And we see the CHEs as a model for that. So this is, like you said, it is, we have built that as a model, and this is for scale across the country by the government, and this is what we see. Now, coming to the next question on whether we just do pilots, I mean, the scale that we have reached over the last 15 years, it's not pilots. We have worked across 10 states, and we have also worked in Indonesia. And we have the model that we have developed has also been scaled in Bangladesh. So it is a scale model we have already, but it is a model that we would like to scale with government. And we are trying to show that this is a model for basically building community ownership for health. And it could address the growing problem of NCDs and elder care in our country. Now, to the first question, which I'm going last, is the entrepreneurship. Yes, we call them entrepreneurs. We started out as community health facilitators because the scope was at that point was only creating health awareness, educating communities. But very soon we realized that these women are putting in a lot of time and effort into this work, and it is not sustainable if there is no benefit to them from this. So then we built in the entrepreneurship, and these women do earn an income from this program. The NCD, the vital screening, because we teach them how to do vitals. So they charge the community for doing regular vitals. They charge them for connecting them on telecalls. We have a telehealth panel with us. We have doctors, qualified doctors, so they connect them on remote consultations. They charge, and it's a very marginal amount that they charge the community. And we also give them access to some health related products like sanitary napkins, nutrition powders, mixes, low cost products. And the CHEs sell these products for a small margin for themselves. So basically, that is how the entrepreneurship is built, so that this can be a more sustainable model in the long term, and they're not just dependent on income from outside.
Thank you. Thank you.
And I've put my mail in the chat, so
Yeah, thank you.
please feel free to reach if you have anything more.
Thank you so much, sir. Any more questions? Ms. Divya S. Nair, she has raised her hand. Please, Divya.
Ma'am, can you hear me?
Yes, yes.
Ma'am, you have just shared us an idea that you're right now using an AI-powered app for communicating with the local people, right? Like if they are asking for some kind of a medical advice, it's very easy for you to use an AI app and you'll be sharing advice for them immediately. That's what you have said, right?
No. There are two things here. The
Okay.
medical advice is never given by the AI app. For the medical advice, we have a teleconsultation with qualified remote doctors who are physicians. And we also have, I mean, for other conditions, gynecologists, pediatricians, we have remote doctors. So for anything medical, clinical advice, the CHE calls the doctor and the patient gets advice. So even if you looked at the demo that I showed, when it does the first step, connect them to the doctor. And then post the doctor medical advice, the AI mainly they use the AI for two things: to get the steps as to what they're supposed to do, and what is the education they need to give, what is the follow-up they need to do. So that the AI helps them. Even if I had put in the AI something like the diet, I am right now in Buxar in Bihar and I need to counsel them on the diet for diabetes. What AI does is ensures the Apna Guru that we have built ensures that they get very context specific diet advice, which the CHEs can give it to the community.
Okay, ma'am, I'm clarified with that answer, but I'd like to know that even though they're giving some primary information about what they have to do, like for example, if I'm having a wound and I'm consulting with a healthcare worker, definitely she'll be looking into the app to get an idea. I'm not talking about the doctor's side, just the first aid measures. So I'd like to know that whether all this information provided by AI is right or wrong, like can we trust them blindly?
Yes.
Like the first aid measures as well.
First aid, when I'm coming to first aid, these CHEs undergo a certified first aid training by Alert. And this first aid curriculum is certified by American Heart Association. So they're certified first aid providers. And for any first aid, that is what they use. That is the knowledge that they use to provide first aid at the community level. And coming to the knowledge base coming from the AI, it is not the general AI. This is something we have built specifically with our content put in there, content related to diet, related to physical activity, related to follow up. And the CHEs have been very clearly instructed, and we have very clear monitoring mechanisms because any patient that the CHE sees, the first step is they have to connect to the telecall. And anything else is after that only for the diet and follow up. So there is no clinical intervention through AI. And the diet and the content that comes in through the AI is being checked, validated. All of this content has been reviewed by CMC, some of our mentors and guides at CMC, and then that has been put into the engine, and that is what is given to the CHEs. I can't hear you. I don't know if it's my network or.
Ms. Divya, we are
I
not
can't
able to
hear
hear.
her. Yeah, yeah.
Ms. Divya, I think so. There's some issue with you. Are unmute, but still there's some issue
We
coming.
can't hear you. Maybe you'd want to put the
languages,
question.
like, is there any particular region? Now can you hear me, ma'am?
Now I can hear, but there's a lag.
Actually, it was a very big question, so I suppose
I think so. There's some
maybe there's some
network
kind of a
issue.
network issue, ma'am.
Yeah, there's
Yeah,
some.
yeah, and I think there's a lag in when you're speaking actually.
Oh, okay. Now am I audible to you?
Yes, I can hear you.
Okay. Ma'am, I'm from South India, Kerala. So, like, I'd like to know whether this kind of provision is available for an ASHA worker working here in South India. That means a regional language is always a barrier. So when we are making a new, like an app for the entire country. So I'd like to know whether this app is available for all parts of, like,
Yes.
for all regions. That means,
Yes. Yes.
yeah.
So right now I just showed the demo I showed you was for Hindi and English just to show that it is multilingual. But it can be like even our curriculum, like it can be contextualized everywhere. And we have done it in Indonesia. We have contextualized the entire curriculum to Indonesian context. And it has been done in Indonesia and it can be done anywhere across India as of now. And the CHE program was also done in the southern states and Telangana, in Tamil Nadu, in Karnataka. We had done this program earlier. And when we go to a completely, and right now our focus has been the northern states because we realize the need is much higher there. And if you look at it, if this has to be used in Kerala, it can always be contextualized and the curriculum can be contextualized language. It can be used anywhere in India. Sorry, can't hear you again.
Divya, I think so. You can just put it over the chat if there is a network issue. Or you have the email ID for ma'am, so you can just send an email.
Actually, we are also dire need of such kind of things. Sure. Now it's not audible.
It's audible now.
But very bleak. It is nice.
Gaps.
We're not able to hear you properly.
Okay, understood. Ma'am, I'll then type it in the chat box.
Chat
Yeah,
box, so you can even send an email to ma'am. She can respond to you on this.
Yeah, sure, ma'am.
You could put it in the chat box and I'll try to answer it. And you can always connect me with me by email too. Yeah.
Sure, ma'am, sure.
Thank
because
you.
we are also looking forward for some kind of a collaboration here in Kerala because we are not getting any kind of advantages from your side. We are also in dire need of such kind of opportunities here in South India as well. Actually, this
so please feel free to reach out and we could connect beyond this call also.
Yeah, sure, ma'am, sure.
Yeah.
Thank you so much, Divya. Anybody else? Anybody else wants to ask any question? Okay, before we end the session, just one question from my side. Since you were telling that you have these camps which are put, and this is like pan-India which you have?
So as of now, we are doing this program in Bihar, UP, and Jharkhand. That is where
Okay.
we are operating. So in our operational areas, we are doing this. We are also, I mean, we are doing a project with ICMR, which is supported by ICMR and along with Christian Medical College.
Yes.
We're working in Bihar and Jharkhand, one block in Bihar and one block in Jharkhand, where we are actually looking at biobehavior changes, looking at follow up with the presence of a person like CHE. How does that improve the behaviors, biobehaviors of people with NCDs, and how does that improve the NCD outcomes? So, this is a 3-year research that we are doing. We are right now in the midpoint and we are doing a midline study. And a lot of what I spoke about is part of this research because it's an action study, it's a part of the implementation work.
So this
So,
is like frequently it happens, like when these
yes,
camps are put. And
yes.
what if like somehow there is some person has some big disease, like
Mhm.
so how do you recommend, like if they are not able to they are not financially, because these rural area people, they are normally not financially stable.
Mhm.
So what happens if they are not financially stable? So do they get any help or something, or you advise, your organization advise them?
So we don't provide financial
No, no,
support.
not finance. Yeah, but advice you can give that.
Advice. So what happens, like recently we had through the telehealth, we had identified a women who had very clear symptoms of breast cancer.
Okay.
Okay, inverted nipple and fluid oozing out, very clear symptoms, and it was ignored. She didn't know that it could be something as serious. And as usual, women have very limited access to healthcare, and they just, unless it becomes very serious. And so finally, when she consulted our doctor, who's an OBGYN, and immediately identified and they were referred. So, what we do in these cases is, and when she was referred, the family did not take it seriously. They did not want to take her to the district level hospital. So our CHE and our staff went in, counseled, followed up, and when the family refused, the CHE accompanied this patient, took her to the district hospital, the got her testing done, and followed up and followed through. And in many cases, where required for the financial, we try to see if they can access the Ayushman Bharat and if they can access the insurance, and they can cover the medical cases. In some of the cases, like we had a case where a person needed an abdominal surgery and he could not afford it. The CHE went back to the village, rallied the village, raised funds within the village for this person's abdominal surgery, and made sure the person got the surgery. So that is how the CHEs are able to collaborate and work.
Mm-hmm. Thank you so much, ma'am. Anybody else who has any questions? Any more
Okay, I
questions?
just see a question from Divya. Divya, as urban areas, yes, access to ASHA workers is limited, but what I mean, if you look at the urban areas, they have their structure. There are care providers, and urban is a completely different ball game, different model. This whole model would have to be changed. And right now, our work is focused on the rural and tribal areas because the access challenges are much more here than in urban areas. But having said that, urban areas have their own set of problems. We have worked with schools in urban areas, and there I think the solution would be to identify the near, because they do have urban health centers, and linking people to the urban health centers would be the solution for urban settlers.
Ma'am, I'd like to add some more thing. I'm not sure whether I am audible.
Yes, now you're audible.
Okay. Ma'am, actually, the main issue women are facing, especially in urban areas, is like managing the menstrual hygiene, because majority of the women work in offices and other institutions. And even though government has put forward certain strategies like not to use sanitary napkins, but they can use other methods, but still some women like to go for the sanitary pads and all. So I like to know that whether government has done something for the proper disposal of sanitary pads and such kind of things, so that women will try to change their napkins and everything as part of their personal hygiene. So this is one of the main challenges. faced by
Yeah.
women in urban settlements?
Urban, rural, everywhere, that's a challenge. I mean, even if you look at you and me, I don't think government has made any solution, right? We have our own solutions for disposal of sanitary napkins, right? We have to segregate. So I don't think. I think here it is more than connecting. The solution here is more in terms of awareness building, creating awareness, and follow up, whether it's urban or rural, ensuring they have access to safe facilities to maintain their menstrual hygiene. Because even in schools, we've worked in about 150 urban schools in Telangana, 150 plus urban schools. So what we find is, even for the girls, we used to, when we started working in these schools, we would find the girls absent 3 days every month. Why? Because they don't have access to sanitary napkins, because they can't afford. Though they have access, as in it's available in every shop everywhere, but they may not be able to afford. Or even if they are able to afford, they don't have a space, a safe space in schools to change the pads or for disposal. So this is a solution that has to be, again, community bottom up driven. I don't think this is a solution that would, the solution would come from the government. It has to be a bottom up approach where, like in schools, what we did, we worked with the parent committees, and we ensured that the school toilets are cleaned up, toilets are made available for the girls, ensured there is a facility to dispose the sanitary napkin, and these are disposed properly. So these, I think some of these challenges need more of a bottom-up approach, rather than depending for someone else to come and sort that problem.
But still, we need some kind of
And
a
education
support.
is the, yeah, sorry.
Yeah. Ma'am, can you hear me?
Sorry, I can't hear you again.
Again. Okay. Now,
Yeah, I mean, I can hear a word and then it goes. So,
it's okay, man. It's okay.
so maybe what I suggest, Divya, if you have more questions, I've put my mail there. We can connect offline also anytime.
Thank you so much, ma'am, for this nice session. And I hope everybody has surely taken quite a bit of it about the rural things which are there, which are currently happening in rural areas, and the initiatives that you have taken up. So we'll surely, if there are any more questions, they can surely let you know over the mail. I'll suggest them to, send it on your mail. I'll share it also with them. And meanwhile, if anything else anybody wants to say right now, before ending the session, you can say that. Otherwise, we can end the session now. I think so. There are no more questions, ma'am. So we'll
Yeah.
end the session. Thanking you again, ma'am, for joining in the session and for such an insightful series, which is there. Every month we keep coming up with such series and hope we have another lovely session with you. Thank you so much.
Thank you so much. Thank you.